our first speaker for the first session today, Nicole Brandt. As a professor and executive director of the Peter Lammy Center on Drug Therapy and Aging at the University of Maryland School of Pharmacy, Brandt has expanded available geriatric training opportunities, including the Geriatrics Palliative Care Pathway, ASHP accredited geriatrics residency, and 2-year post-PharmD fellowship. She was named the 2019 recipient of the American Geriatric Society's Dennis W. Janigan Memorial Award for her leadership in geriatrics education. She is currently leading initiatives to integrate sustainable pharmacist-directed services to help older adults with multiple comorbidities at the MedStar Center for Successful Aging. She was a Fulbright Program Specialist from 2023 to 2024 with the University of Helsinki School of Pharmacy to work on age-friendly care initiatives. Please welcome Dr. Nicole Brandt. Thank you.
Awesome. Thank you, Nicole. Thank you, Erin. And thank you all for jumping on this program on a Friday morning. And as someone said, happy Friday, happy Nurses Week. It's truly a pleasure and an honor to represent the work today that is funded by the John A. Hartford Foundation. And a special thank to Guardian Pharmacy Services for supporting us in this work. This is a collaboration with the American Society of Consultant Pharmacists and the University of Maryland School of Pharmacy Lammy Center that I have the honor to direct. So I know many of you wear many hats in this room, and I want you to feel free as an educator. I love questions. I embrace questions. So throughout, pepper me with questions. I know from speaking with both Nicole and Erin and Lisa, putting this material together, that some of you may have familiarity with age-friendly healthcare, age-friendly health systems, and just wanted to make note of that. I'm going to just note that I have no relevant financial relationships with commercial interest, and I won't be discussing any non-FDA approved uses of any drugs, but I do feel very fortunate to have worked with many partners through the years. My passion has been improving medication safety for older adults through practice, through service, and through, of course, advocacy. And I think now more than ever, we need to collaborate and work to make sure that we continue services that are meaningful for the people that we provide care for. So just to give you a sense of what we hope to accomplish during this time together, we're going to describe what age-friendly care is and the 4 M's. Some of you may hear 4 M's, 5 M's, but we'll talk about 4 M's because of the work with the Institute for Healthcare Improvement and the John A. Hartford Foundation. We're going to talk about opportunities for pharmacists and long-term care pharmacies to help provide age-friendly care and some of the work that we're doing through this grant and our programs. We also are going to talk about strategies. We realize that you have many things that you have to do throughout your workday, but how can we adopt these principles? How can we implement these principles? And how can we show outcomes that are meaningful, both to our facilities, to our payers, and most important, to our patients and the family members that we work with day in and day out? And then we know that there's barriers to implementing 4 M's in post-acute and long-term care settings, but we know that if we work as a team, we will overcome those barriers together. And I think that's really the spirit of the talk that I hope to bring to you today, is the importance of teamwork, interprofessional work. I always say my energy gets rejuvenated when I get together with like-minded peers. So this is a wonderful forum, but I'm actually at the American Geriatric Society in Chicago, where we've been talking a lot about age-friendly health systems and age-friendly care. So for those of you maybe not as familiar with age-friendly health systems, this is basically a movement that's been going on for almost 10 years now to really improve all care with older adults that is equitable and age-friendly. And we know, especially in nursing homes, that evidence-based practices may take some time to get adopted, but we're using this framework, and many practitioners, whether it's pharmacists, nurses, physicians, social workers, case managers in our communities, they love this framework because it simplifies a way to have the conversation, to bring that person, patient-centered care to the forefront by asking questions about what matters to the older adult and their family. And by using this framework in collaboration with a healthcare team, it has shown, and we will share some of the data today, how it's improved outcomes that matter to our older adults. So the 4 M's are what matters: medication, mentation, and mobility. So again, gives you this kind of overview. So through the 4M's framework, it represents a core health issues for older adults. And it really has distilled down decades and decades of evidence that's existed. So for instance, the What Matters work has really been generated by Dr. Mary Tinetti's work and others' work. And so there are resources about patient priorities care to help get at that what matters question. And again, it helps to simplify, reduce implementation and measurement burden. And you'll hear throughout my discussion with all of you today on how you can incorporate this into your workflow, so there's not more burden on your staff. One of the things we've been using both in our clinical practice, where I serve as an interprofessional team member in both ambulatory and inpatient and long-term care, is the My Health checklist. I really love this because it's free. I'll say that word, it's free, and it's available in multiple languages. It's a part of a program called the Conversation Project, and it was supported by AARP to make this resource available in multiple languages. It was co-designed with older adults, and I really find that it really helps to help the older adult and the family member engage in conversation with their other family members, but also with their healthcare professionals. So we've been using these in our communities as part of our educational series when we go and do events with our older adults. We use the construct and philosophy of IHI. If you're not familiar with IHI, the Institute for Healthcare Improvement, it's a quality improvement organization. So one of the mantra that I've been using in both my classroom on the university side and a classroom like this, as well as my classroom in the community, is all teach, all learn, all improve. I learn so much every day from the people I serve and that I work with. And then by working together, we can improve the delivery of care. So I just wanted to give perspective on this movement. I feel very fortunate in my career when I reflect upon movements. I spent 5 years at the Centers for Medicare and Medicaid Services working in the long-term care division, and I had amazing mentors through the years. One of them taught me about culture change in long-term care, and then I was able to help launch the initiative to improve dementia care, also known as the Antipsychotic Reduction Initiative, and some of the work that we've done at the university. And then this movement, the Age-Friendly Health Systems movement. So when I think about movements, I think about it's not just one space, it's across multiple spaces. So IHI and Age-Friendly Health System partners piloted the 4Ms in 5 pioneer health systems. So it really started in hospital systems. In our state of Maryland, a small but I say mighty state, we had the Anne Arundel Medical System, which is a community-based system, be a part of one of the pioneers. And so through that, they realized in order to implement sustainable change, you've got to get the communities involved. So we launched the first action community. I joined the faculty with IHI back in 2018. So I was at that beginning cusp. I remember our action communities when they in person, which was so monumental, of getting pioneers together in a room with a whiteboard. And I always say that is where the magic happens, is when you get together and you start with a whiteboard and you say, how can we do this together? And then it just grew. And leaders within IHI and within the John A. Hartford Foundation and the American Hospital Association, as well as the Catholic Hospital Associations, got together as well. And they started working on how can we improve these action communities and how can we offer them. And then what happened? near and dear to all of our hearts. They started piloting this work in 2020 in nursing homes. And we all can reflect on what was happening during the pandemic and the care within nursing homes. So it was a tough time and continues to be a tough time for long-term care facilities, but this work started getting piloted in nursing homes and really has helped to improve the, the framing out of care initiatives and quality improvement opportunities. In 2021 and still to date, IHI has an open school course to teach students, and I see students loosely. These don't have to be that you're enrolled in a terminal degree, but any person can access this around the world. So you will see that this age-friendly health system movement is not just here in the United States, but it's actually global. So I've been able to coach health systems, not just here, but also in Europe, as you heard with my Fulbright, and Middle East, and in Australia. So it has been so amazing to hear about the same struggles people are having, but same opportunities to improve. And then if we needed a bolus in terms of getting people to adopt and implement, the Centers for Medicare and Medicaid Services released starting January 2025 an age-friendly hospital measure, and I'll speak to that a little bit. That will be an attestation measure for the first couple of years, and as we all know, measures so well in nursing homes will turn into a performance measure in the future. And as we can foreshadow how this movement has moved across care settings, that hopefully there'll be similar measures within other care settings, such as nursing homes. So very exciting to see this change happen. So here's, for those of you not familiar with the CMS age-friendly hospital measure, and I should say, having led action communities from 2018 to 7 years later, we'd have about 20 to 40 hospital systems or nursing home providers, ambulatory care providers, other types of programs as a part of the action community. Our action communities are hundreds of systems now, and these are free. And so on this age-friendly health systems resource and news on the Institute for Healthcare Improvement, you can learn about these action communities, and you can get with like-minded facilities, whether it's assisted living, nursing home, PACE, community-based, that really just share resources. Again, this is a free resource at this time. But in the hospital measure, again, this is going to be mandatory reporting for anyone that is part of the hospital inpatient quality reporting program and pay for performing. And they have to report on 5 domains. And if you look on the right side of this slide, these 5 domains map well with the 4 M's. And these 5 domains are part of a composite measure. And I know measures can be a little bit challenging to operationalize, and composite measures for that point, meaning that you have to attest to doing all 5 domains, are something that is going to take some time to build in to our workflow and our systems. But to think about that, eliciting patient healthcare goals is focusing on what matters. All of you do advanced care planning and are eliciting those goals dynamically as a team. So again, this works well in long-term care. You've got a consultant pharmacist, senior care pharmacist, age-friendly pharmacist. We're going to talk a little bit about what is an age-friendly pharmacist, but it's raising that awareness, competence of our pharmacists to looking at medications and to put it in the context of what matters to our older adult, looking at the implications positively and negatively on mentation and mobility. So the systems are looking at that as a part of this measure. Frailty screening and intervention, and again, looking across mentation, mobility, and medication and that interaction to see what we can detect and what can we intervene on. We also further look at social vulnerability, and we know that placement out of nursing homes, but out of hospitals, are highly impacted when we look at our social systems to address all levels of care to meet the needs of both the patient and those who care for them and the care partners. And then one of the things, and I'm so grateful for the people that are on this call, because I look at you as the leadership and the change agents and the champions to help continue to work in this space. And so when I think about progression, having leaders that work across care settings is so important. So I'll showcase with you just an opportunity for long-term care to be working with health systems to be more age-friendly. So, and then just talk about a growing movement. This is a heat map that is based on IHI's data. This was taken just recently from the April data, and you can see where places, and there's a lot of opportunity out west. I know we didn't hit anybody from, I think we got one Utah I saw out there, but there's a lot of opportunity to grow, and especially in the long-term care space. So there's currently 51 hospitals, practices, convenient care clinics, and nursing homes. And again, this is growing globally, that are participants of Age Friendly. And Age Friendly has different levels. There's Age Friendly health system participants, and we'll talk a little bit about what does that mean. And then there's centers of excellence, and then sustainable partners in terms of who are spreading this work. Either way, highly recommend go to ihi.org/age-friendly, learn more about these opportunities to be a participant in this work and a partner. So the first question, is your care setting recognized as an age-friendly health system participant? And I know I can talk through this as you're thinking. This is a simpler question. I just gave you two polling questions. So this one's a simpler for you to answer at this time, but feel free to chat in, but hopefully you'll have access to polling as well. Wow, love it. 53% said yes, 47% said no. Fantastic. So we can see, just as we kind of talked about in planning this session, that there's going to be a variety. But I think what's so important by seeing this split is you've got your own experts within who've gone through this process that can share some of their resources and experiences. And I think that's just a really valuable asset to your team. So I'm going to move us on next opportunities. All right. So, as I kind of alluded to earlier, this was a wonderful article that was published in JAMDA. And some of you may be familiar with, formerly known as the American Medical Directors Association, now is PALTC. Really hard for me to say that, but the Post Acute Long Term Care Medicine Society, and have been very involved with that organization through the years. So this article was published, and it focused on something I think all of us can relate to: transitions of care that don't go very well, and how we need to work with age-friendly hospital systems to make our long-term care settings even more age-friendly. Julia Adler-Milstein is out of UCSF in San Francisco, leading actually a research arm to age-friendly initiatives. So this case, I'll just highlight it, is of an 86-year-old woman. She was admitted to the hospital with a hip fracture after a fall at home. I know that we're working with our trauma center, and falls are one of the biggest events that lead to some sort of surgical procedure, which often leads to this constellation of downward aspects, from delirium to potentially death. And so I think we need to think about, what are we doing, one, to help with safe mobility, preventative, but also if someone has a fall, fracture, and has a surgical procedure, how are we maintaining their function? So this case will illustrate what we can all do a little bit better. So she has an underlying mild dementia, and all of us know that individuals with underlying mild dementia are even at greater risk for developing delirium during a procedure or during the constellation of a hospitalization, where they're often sleep deprived. In her case, if she does not wear her glasses or her hearing aids, and there's been so much discussion on hearing with cognitive function alone, but especially with delirium, she does not maintain a good sleep-wake cycle. She also needs a walker for standing and walking around the house. So, the pharmacist in me is like, well, these aren't very many medicines and maybe wouldn't even hit our polypharmacy measure. But I always use my definition of polypharmacy as a practitioner is more medications used than clinically indicated. That's polypharmacy to me. And I always pause when I see high risk medications. So when I see medications like oxycodone, I think to myself, okay, what are we treating in terms of the pain? And especially when it's an as needed, how often are we giving it? And then when I think of alendronate and the administration, especially someone who's in a hospital setting, how are they giving these medications? So those are just some of the considerations, let alone we've got someone on a calcium channel blocker and hydrochlorothiazide. So I didn't even give you any sort of blood pressure measurements in there. So just let's talk through this particular case. So they're following the standard discharge protocol. On the day of discharge, a discharge summary is generated and sent with Mrs. Brown. Still baffles me the amount of paper discharges that we get in our practice. But I think, as you'll see throughout this case, the importance of having access to electronic health records. The discharge summary is focused on the surgical issues of a hip fracture. However, the discharge summary does not include the 4Ms assessment work done by the inpatient team. So this particular unit was part of the age-friendly health system work. They did an amazing 4Ms assessment, focusing on her delirium, which again, the hearing aids, the glasses, the dentures, and avoiding antipsychotics. So, when we think about getting an allergy history or an intolerance or a sensitivity, that doesn't always get conveyed very well. And I can say that as a pharmacist, how do we share that with others that when they were put on antipsychotics, it made them worse in terms of their somnolence and confusion. With Mrs. Brown, she got admitted to the skilled nursing facility. The skilled nursing facility team reviews the discharge summary, and of course, they conduct their own initial assessment. They are unaware of this patient's history. Therefore, they do not ensure that she gets good sunlight during the day. She doesn't have her hearing aids, glasses, and dentures. They're not unpacked from her belonging. And then, unfortunately, she becomes quickly confused because of the sleep issues, and she's napping all day with some hallucinations and yelling out at night. And no deference to the skilled nursing facility team, but they prescribe an antipsychotic medication. And unfortunately, her decline is precipitated. She then becomes more confused, doesn't get up, and her mobility is worsened. So we look at this as, something I think we can all relate to, and why I choose this case when it's in the public domain. And it really highlights opportunities for improvement. And that's what we're here for, is how can we improve the work that we're doing? So there's specific opportunities and recommendations from this article, and that ideally the hospital and the skilled nursing facility would have an interoperable electronic health record system that are designed to ensure key information. So for instance, a 4Ms assessment work, a delirium prevention plan. And so I know that some electronic health records are building some of those resources in there that can be shared with other care settings. So I know in our health system, I work at MedStar, we put together a 4Ms documentation that can be shared from inpatient to outpatient. We still have a ways to get it to our skilled nursing facilities, but some of our providers are medical directors there. So we're working on that kind of soft handout too. Because of this, we need to think about how we can highlight some of this information in our discharge summaries if we are just sending those copies over in some sort of physical or electronic form. And I think it would be further supported by some standard protocols in skilled nursing facilities that involve, again, that integration with skilled nursing facility care planning. So I think this is an opportunity for those of you in administration or working with administrators on quality initiatives. This is a great one. So there was a session at PALTC within the last year that talked about facilities, hospitals, and the pharmacy, and I'm going to call it the pharmacists in particular, hospital pharmacists working with long-term care pharmacies to help in terms of some of that handoff with medications. And so I think this is a great opportunity for improvement for each and every member of the team. So what I wanted to share with you is you are not alone, okay? And there are resources out there that can help you in terms of some of your implementation efforts. And I don't think I saw Pennsylvania tapped in here, but the Teaching Nursing Home Collaborative is implementing ways in which to use the nursing home as a teaching model. And this improves nursing schools and nursing homes working together. We actually presented, one of our nursing students actually wrote up an article in Caring for the Ages, which I think some of you might read and be familiar with, by PALTC. And she really shared her experience where she went out to a facility. She was so empowered by that opportunity to learn the 4 M's in a nursing home that she changed her career from planning to be a hospital nurse in the ICU to working in long-term care. And I hear that from our learners, that oftentimes all they know is hospital systems, that they don't get to work as much in long-term care settings. So I think this is a great way to think outside the box. And I think many of us have many schools, not just nursing, around us that we could use as a practice site. And one of the things we've been doing in the state of Maryland, and very fortunate to have a strong relationship on our interprofessional campus, is we've made our campus, which is a professional campus, an age-friendly university. And so one of the guiding principles with age-friendly universities is to work with our community. And when I say community, that can be long-term care settings. We actually work in underserved senior housing sites where we're bringing services that are age-friendly into those sites. So I think we can all be creative in the work that we're doing together to really improve the delivery of care. And then there's a coalition. I didn't ask a polling question, but if anybody wants to chat in, the Moving Forward Nursing Home Quality Coalition is putting together resources for nursing homes to help them advance work in this space that is age-friendly. This initiative is led by the Institute for Healthcare Improvement. And some of you may know Dr. Alice Bonner, who was at the lead at CMS in the long-term care division for some period of time. So she's leading these initiatives. And the two guides that I just highlight here are strengthening resident councils, which one of the major aspects of age-friendly care is bringing the older adult's voice into leadership and feedback for all of us. And I am so refreshed. I just led engagement council at one of our meetings here at AGS. And every time I hear from our older adults, I always learn, what can we do better? So I think it's just so important. And they have another guide on addressing residents' goals, preferences, and priorities. So lots of resources out there. Highly encourage you, if you have not been part of this organization in terms of receiving these resources, you can scan this to subscribe with your thing, or you can just visit the johnaharfordfoundation.org. And I'm not sure if all of you are aware, but this month of May is Older Americans Month. And actually the John A. Harford Foundation put out a movie. So that is a free on their website, which highlights, and Martin Sheen is one of the moderators, highlights the importance of age-friendly care from the older adult's voice. And I know that when I get back to Maryland, we are going to have a film program with our students at a facility. So our older adults and our interprofessional students together watching this movie and just doing a brief discussant with that. And I think there's just so many ways to bring our communities together to improve age-friendly care. So if you haven't figured this out, I'm very passionate about this work because I truly feel that it helps to start conversations that are sometimes very difficult to do. So implementation strategies. We are currently working on this project, and I want to shift the space here to pharmacists, long-term care pharmacies, and facilities. So as I mentioned at the beginning, we're working with ASCP as part of the John A. Harford Foundation to train pharmacists and to engage long-term care pharmacies to be more age-friendly. And as we think about this, and I know that Erin, Nicole, and others through the Guardian Pharmacy Services, have been shepherding this work along with us. And I think what's been just really important that came out during one of our conversations, and it sparked when I was doing some work in Pennsylvania, and I know some others have heard this, just by the simple fact fact of the facilities sharing with the long-term care pharmacist and pharmacies that what matters help to reframe the recommendations and the acceptance of that work. So we've been working in this space over a year now. And we have an advisory council. We formed a learning collaborative. We've done some needs assessment. We've put together some training that I'm going to share with you. And we're really getting out now and pounding the pavement to find facilities and partners who want to implement this in long-term care settings. And that's where this takes a team effort. So we're really excited that we have leaders from each of the regions to help us in these implementation efforts. So I'm trained as a pharmacist. I'm not an implementation scientist, but what I've learned that every touch, every conversation, every angle in which we can bring this to our communities helps. And so I, again, thank the opportunity for being in front of you all today. I just want to highlight last year we conducted a needs assessment of our members within the ASCP. And I think just what's important to note is that 52% of the people who responded to this needs assessment practiced in long-term care, and 62% were aware of this age-friendly health system initiative, but only 20% of them reported facility level involvement. So that really showcased to me that we've got a great opportunity. And what we also noted is that only 17, almost 18%, less than that 20%, were comfortable assessing the set of 4 M's. And so we need to work together to help with the assessment and the act on. And I think some of the areas that helped us to inform the education and also some of the in-person trainings was looking at mobility and mentation. And I think we know that within long-term care, we have amazing therapists and partners to help us in that. So now I'm going to shift another polling question to you because we're going to take a deeper dive into some of the medication-related aspects. But which of the following medication-related aspects has been most challenging to implement for you? So I know that 50% of you may have not implemented age-friendly initiatives yet, but if you were, what do you think would be the most difficult for you to implement? So thank you. Okay, fantastic. Love it. So 50% of you, and this is very common, the measurement of impact in terms of looking at that. So I think that's a nice segue to our slides that'll come in terms of how you can potentially look at impact and look at your data. And I think what's important is we've got many leaders on this call who have a lot of data that they can share that can help us with measurement of impact. And I think what's most important is also to bring in measurement of impact from the patient, resident, family lens as well. And we're seeing that that is an important motivator for change. So just to highlight, after the needs assessment and based on some of the implementation efforts, we put together this educational journey. So it's targeted for pharmacists because of the grant, but I can tell you that everyone will benefit from some of these modules, if not all of these modules. And what we've been promoting is an age-friendly pharmacist digital badge, but we also have an age-friendly champions that we're really promoting as well as part of this movement. And so highly recommend. It provides you continuing education, and those of you that are board certified, it also in geriatrics will provide you some of your BCGP credit. So we hope that you will join us there. So again, just to show that we wanted to make this interprofessional as well as geographically and site difference. So the first one, It Matters to Me, Dr. Morgan and Dr. Delach are out of Oregon, and they're in a post-acute long-term care setting with some focus on subacute stay, and they talk about how it matters to them. The best part about this, I think there's so many richnesses within these 1 hour sections, but we took a lot of time putting this together to give you some pointers on what you can take back. So again, visit our website. These sessions are free, and depending if you're a pharmacist, you could get some additional credit. The next site, which focused on medication optimization, a term near and dear to my heart. It's not just about stopping medicines, but optimizing medicines, simplifying medicines. It was some of the work that we did during the COVID pandemic, where we focused on medication optimization efforts. And this is a colleague of mine, Dr. Corton, and Dr. Chow was one of my past trainees. Too Much on My Mind, Age-Friendly Approach to Mental Health, that mentation M. And those of you who may know Dr. Fick is internationally known in the world of delirium, and Jennifer Urso is a leader in long-term care pharmacy. And last but not least, we had a pharmacist and a physical therapist work together, and Vic did an amazing job talking about different tools to assess mobility, and they were focusing on a program that was in the post-acute long-term care setting, looking at individuals who had had falls or at risk for falls, and how could they improve mobility. So again, can't say enough about this. And what we then did in terms of implementing some of these educational efforts, we have this, our Emerge team, as well as Age-Friendly Mentors, and we used an existing ASCP map to map out the different regions. And we have 22 pharmacist champions, and then we have 5 Age-Friendly Mentors, and most of them are medical directors from the different regions, as well as an implementation scientist to help us with our efforts. And so we then took this data. We actually just presented this today at the American Geriatric Society. We actually presented it last night at the American Geriatric Society. And I wanted to showcase this to all of you. This is focusing on nursing homes. We used a system software, ArcGIS, which is a geographical information mapping system, to kind of give us where we see both the presence of what I call IHI recognized nursing homes. Those are those little blue dots. And out of the 14,781 nursing homes that are in the public data provided by CMS, only 789 are recognized. So we've got a big growth curve. So when we show this data, people are like, well, you've got a lot of opportunity for improvement. So we do. And so that's why we've been working with the Moving Forward Coalition and some of the other coalitions to help get facilities on board with this work. And so we can see that these gray, yellow, and then pink, well, pink to yellow is the high intensity of CMS nursing home sites. So there's a lot of, I would say, differences across our geographical areas. And the reason the Midwest, I thought this was fascinating, like all these blue dots right here in the Midwest. I see we can do some work down there in Georgia, call out to our friends in Georgia. But in the Midwest is because there's a fair number of VA sites, as well as another long-term care facility chain that has a good number within that area. So just wanted to showcase an opportunity for improvement. And we'll use this as part of our tracking over time. Our champions just started really in February, and they started reporting out their data, and about 10 sites have been reached out to be recruited in this work. So the last segment of my talk is overcoming barriers. So as I said at the beginning, I realize that we are all very busy. And so we've simplified this implementation into a guide, and it's basically built from facilities who have done this work. So again, it's made to make it easy for you. It includes printable worksheets. It includes our CNAs, an instrumental part of the team for age-friendly care, and colleagues through the teaching nursing homes. And then there was 10 pilot nursing homes that did this work. Again, each of these resources I share with you are on the internet. They are free, they are downloadable, and I encourage you to start to use them. And within this movement, what I love about it is it's very simple. You have to assess and act on. And I think from my decades of experiences working across care settings, including long-term care, is we're great at assessing things. Um, but I think we can all do a better job on acting on them, and especially acting on them in a way that focuses on what matters to older adults. And I'll give a for instance, as a pharmacist, I know that we're often managing multiple coexisting comorbidities, multiple medications, and that may cause a very disruptive medication administration scheduling for both our nurses as well as for our residents that we care for. But some simple things about streamlining, potentially getting rid of some of those medications can really reduce the burden, not just on the patient, but also a resident, but also on that healthcare team. So something simple like that to act on. And during the pandemic, I remember vividly where we had a facility run their medication administration times. And again, I'm a pharmacist, so I get kind of excited about peaks and troughs of medicines. Well, it looked like an immediate release that only lasted 2 hours. It seemed like every 2 hours medications were being passed. In a time where we have staff shortage, there's got to be better ways to do it. So I think working together on that age-friendly care, because oftentimes I hear from patients or residents, I'm on too many medications, they're disrupting me throughout the day. How can we make things simpler? And that's just one example to assess and act on data that's already there. And that gets at medication measures that matter, such as medication complexity. And there's different ways in which you can calculate that. So for our VA systems, a colleague and friend of mine, Dr. Andrea Schwartz, the senior author on this paper, looked at early clinical and quality impacts of the age-friendly health system in a VA. Now, those of us who've ever practiced in a VA, I worked there for 12 years, they have a lot of structured data and data sets, which makes it a lot easy to sometimes run reports. But I think what it showed is data that matters when you're talking with other team members and potentially C-suites, I like to say corporate executives, on why they should invest in age-friendly care, because it reduces emergency department utilization. It reduces hospitalization by 30%, and it increases 19% discharge to community. So again, this is Veteran Affairs Skilled Nursing Facility. So again, data that matters. It also showed long-term the same kind of impact on ED visits and hospitalizations as well. So this was published in JAGS and is a great resource to look at how they looked at this particular data and meaningful measures. So, and within the data, I think it's important to think about some of the work that you're already doing. So this nursing home in particular focused their work on antipsychotics, and they didn't have, fancy electronic records, but they did, but the CNAs, excuse me, didn't have access to the electronic health records. So they actually kept a binder for the CNAs to use as an easy reference of what matters to residents. And then as part of their quality improvement, they would screen for dementia and depression. They would offer a lot of non-pharmacologic approaches, and they were able to show a reduction. And there's a series of case studies that are available for you that you can go to. And this is one of those case studies. And I think when we talk about not just the surveys or these, medical measures or medication measures, bringing those quotes to our communities is really important too. So this was a family member of a new resident, and feeling like they were in an environment where they could ask questions and that they were really being cared for. So I think that's part of many reasons why this age-friendly health system movement has been very successful. So I want to make sure we leave it some time for Q&As, but the 4Ms as a set is an approach to providing age-friendly care. It offers every member of your team the ability to work as a team, and the pharmacist is a vital member of this team, but we need to make sure that we've got bi-directional communication, and as I illustrated with the case, not only from the pharmacy to the facility, but the facilities to other care settings, to make sure that these transitions of care are not causing more harm than benefit. And so will bring to you some additional resources. I always say a good educational program is one that gives me resources that I can take back. So this is our age-friendly pharmacist site, where I index some of the resources and tools that we talked about. And then we would love for you to connect with us. We are putting out on a regular basis different tools, resources, and updates on this work. So at that time, I think I'm going to stop sharing and open it. Hopefully I'm on good time for Q&A.
Yes, you are doing your Christina D. Christina is a consultant pharmacist with over 10 years of experience in skilled care settings. She serves and leads many nursing